welcome to PCR Webinar Roundtable on Bifurcation PCI. My name is Goran Stankovic, I'm coming from Belgrade, Serbia. And to discuss various aspects of Bifurcation PCI, this year we set up Bifurcation Continuum with series of different educational formats combining PCR webinars, learning sessions at EuroPCR together with PCR online resources. Our chapter 1 today is a step-by-step algorithm for provisional side branch stenting in non-left main bifurcations with specific focus on stent optimization techniques. It's a pleasure to introduce that with me in the PCR studio are Jens Flensted Lassen from Odense, Denmark, and Dr. Dejan Milašinović from Belgrade, Serbia. Dejan, why do you think that stent optimization is so essential?
Well, in bifurcation stenting, optimization is used to adapt our stenting result to the underlying patient's coronary anatomy. So as a general principle, what we try to achieve when treating a bifurcation lesion is to reconstruct the underlying anatomy. And different optimization techniques are there just to do that, to help us to achieve this goal.
Thanks. Jens, what is your perspective on this?
Exactly the same, I would say. It's very important to realize that the first stent you put in provisional stenting is actually the backbone for the entire procedure. And because of that, you need to have a toolbox of different techniques to optimize that result. Because we have to remember that every person, every patient is an individual, and the anatomy is different. So we need to actually modulate a stent to a unique anatomy.
Yeah. So here are the learning objectives of today's roundtable. Of course, we will discuss the indications and different steps of provisional side branch stenting with specific focus on available techniques for optimizing the results. So main question is why, what is the rationale for performing stent optimization, and how to do it. It's actually tools and techniques to achieve this. And to do it, we want to put everything in a real case example. So, Jens, you wrote the last article on consensus of EBC for bifurcation stenting. So, why we actually need to perform optimization according to this specific group?
Thank you very much for the question, Goran. I have to admit that I was only the one who did the writing. Actually, the essence of the consensus documents are built in the entire European Bifurcation Club community. But one of the things that is really important and which is actually emphasized in the slide is we need to keep things simple. We need to limit the number of stents, which means that if possible, we shouldn't put in too much metal. We need to respect the original bifurcation anatomy and try to reproduce it while we are modulating the stents. And we need, of course, to aim at a well-opposed and well-expanded stent with a limited overlap to achieve the best thinkable result.
Yeah, to limit amount of metal and to respect the anatomy. Then can you remind us on important characteristics of bifurcation anatomy?
As we can see from this slide, and that's really a very important message, is that there are actually 3 diameters of a bifurcation. And importantly, diameter of the proximal main vessel is not the same as the diameter of the distal main vessel. And this has many implications. The most important implications is that in a stent, that's not the case. The stent has a uniform, it's not tapered, it has a uniform diameter. So here, we implant a metallic tube that has 1 diameter into a bifurcation that has a difference in diameters between the proximal and the distal main vessel. Also, when we implant a stent into the main vessel, there are implications for the side branch. So we need to be aware of the fact that if, for example, as here in the slide, and on the next click you will see what can happen, if you implant the stent into the main vessel according to the reference diameter of the distal main vessel, what you can have as a result is the compromise of the side branch due to carina shift. So we need to be aware of both when implanting the stent into a bifurcation lesion. Difference in diameters, but also of the implications on the side branch.
I would like to ask Dejan to present one case from everyday practice.
This is a recent case in our cath lab. This was a lady, 60 years old, who suffered an inferior STEMI and was treated with primary PCI. She recovered well. there were no major comorbidities, and ejection fraction was preserved, and there was no renal failure. So what was left to be treated was a non-culprit bifurcation of LAD, as we can see on the next slide. This is the baseline anatomy that we had. So as you can appreciate here, we have a LAD D1 bifurcation, and then the first step in this case for us, and you can see it here, is to analyze the anatomy. And we try to do it in a stepwise way, in the fact that there are at least 4 points that you may consider when analyzing the anatomy. First, you need to concentrate on the main vessel. You need to appreciate the reference diameters. You need to be aware of the difference in the diameters, and you need to be aware of the length of the lesion. Secondly, you need to take a good look at the side branch to analyze the length and the diameter of the side branch. And of course, you need to take care of, or to understand the bifurcation angle and plaque distribution. In this case, as a summary, what we can, I think, say is that the diagonal branch does not seem unimportant. So it probably is a clinically important side branch in this case, so we need to take care of it, and we need to really concentrate on how we optimize our result to preserve the side branch.
So if I can summarize, we actually have long diffuse disease of LAD, bifurcation with significant side branch. There is only one diagonal. So according to recent reports, one diagonal, especially according to Dr. Bong Kwong Koo, one diagonal is usually significant, supplies more than 10% of myocardium. So we need to be very careful and preserve both branches. And what would be the initial strategy? One, very simple, crossover stenting without even wire in the side branch. Second, put 2 wires, but then focus on main vessel stenting and just perform proximal optimization technique. The third option is to combine proximal optimization with final kissing balloon inflation. And the fourth one is upfront 2-stent strategy. Jens, question for you. What would be your strategy in this specific case?
Well, it's an excellent question. The easy part is it will definitely not be a 2-stent strategy. And the reason for that is actually that if you go for a 2-stent strategy, you will end up with 2-stent. I don't say that you don't need 2-stent in this particular case. It could be. But if you start provisional, you can stop at every step during the provisional. So my first step would actually have a strategy that is based on provisional stenting as the backbone, with a proper optimization during the procedure, and see how far we go. So that would be, put in the first stent would be my strategy.
So provisional. This is discussion that we already had last year when we had PCR webinar. I like to reiterate again, provisional is philosophy. Provisional does not mean single stent. You agree with me, and we created together and discussed this strategy. It's actually sequence of decisions. You start by stenting the main vessel. Main vessel is why we treat bifurcations, and then we try to evaluate result. And then when we discuss, especially in this specific case, upfront 2-stent strategy is probably not necessary option at this step of discussion. Crossover only is also probably not acceptable because we discussed this is significant side branch. So we remain with 2 options. One is to do pot. The other one is to do pot and kiss, and maybe final pot. There are many options and many acronyms recently presented. So if we decide to stent, based on all publications, based on EBC consensus, what are the major decisions that we have to make?
Well, bifurcation stenting is therefore also interesting because putting the stent into the main vessel is the beginning of the story. And I think you can appreciate it very well here from this slide. Just putting the stent into the bifurcation is the beginning. As you can see on the left-hand side of the slide in green is the way it is recommended to do it, is to size your main vessel stent according to the distal reference. And if you do it that way, you end up at least with 2 things that need a correction. First, you see there is a gap in the proximal main vessel, and then the side branch ostium has no scaffolding. If you do it the other way, if you size your main vessel stent according to the proximal diameter, and you see it in red here, then you would already compromise the side branch. And we said we want to avoid that. So just concentrate. The first step is main vessel stent according to the distal main vessel diameter, and the story begins here. We have more to do.
I agree. We receive question from our participants what panel recommends regarding side pot, but we are still not yet at that stage. As we said in provisional philosophy, we go step by step. First step, stenting, and then after that we have to evaluate the results. And thank you very much for putting in the perspective. So you recommend to select stent according to distal main vessel diameter, and here is the result after stenting. So what is the next step? Looks adequate according to angiography. We also see no major compromise at the ostium of the side branch, so probably it was respected to select according to distal main vessel diameter. And we have three options here. First option is to do nothing, just finish procedure at this stage. Second is to perform pot, and the third one is to perform KISS. What we learned so far, maybe Jens, you can guide us through your decision-making process.
Well, thank you. Yes, it seems to be a nice result, but we have to remember that this is in this view. Maybe we should have a further view if we would like to really appreciate the result. But I would like to go a step back before we put in the stent and take outstep from the slide just before the green panel, because what we really need is to be aware of the two steps. There was a gap between the proximal stent and the vessel wall. There was a very, very fine, precise optimization in the distal part because the stent was implanted with respect to that, and there was a preserved side branch, which is actually what we see here. What we maybe not are able to see is actually, is there a proper apposition of the proximal part of the stent? I would not think so, but I can't see it out of the angiogram. So I would go back again and say we need to have a toolbox, and we need to have a toolbox of optimization techniques. So now we have done the first step, which I totally agree was the start of the journey. The next step would be to be sure to have a proper apposition in the proximal part. So my immediate next step would be to do a pot in this situation to make sure that we have a proper apposition proximally.
Yeah,
and the reason
I can interrupt you for a
yeah,
second.
Yeah, you can.
There is a question, what about jailing FFR wire in the side branch? So question about jailing wire, FFR wire at all in bifurcation PCI. And the other question is, do you consider recrossing into the side branch before pot? So I think it's very important to think three-dimensional, and I believe you should share with us your experience from the visible heart and explain why we should not remove wire and recross before performing pot.
Yes, actually, I think I would take access from the question raised, because if we do a pot at this stage and we have an FFR wire in the side branch, then we will of course jail that wire quite roughly between the vessel wall and the stent. It is doable, and it is shown that it's doable. But actually, what would we have of information from the FFR wire? We would like to know if the pinching of the ostium in the side branch actually means something. And there we have to be very, very strict on the physiology and the pathoanatomy, because when we put in the stent, we may do some harm to the vessel wall.
That's exactly next question.
Yeah.
Probably the first step should be pressure guide wire analysis of the side branch. What do you think about that suggestion? To put that into perspective, if I need an evaluation of the side branch with a pressure wire, I would do it before I put in the first stent, because I would need to know if there is a significant stenosis in the proximal part. If there is a significant stenosis in the proximal part in a side branch, it will raise two questions for me. The first would be, is it clinically significant? Because there might be a pressure drop, but does it cause angina, or will it put a risk on the patient? So that's the first option. So I don't really have a clinical answer from an FFR measurement of the side branch, but it would help me in decision making. If I put in the FFR wire afterwards, then I have to
realize that there might be edema in the area, which will be away in a month. There might be a hematoma, which will be away again in a month, which means that if I make a decision of put in another stent at the stage of the initial procedure, I may do it on a wrong information because the FFRY is difficult to really evaluate at that stage. So I guess I don't think we could cover it in even more depth, but maybe we have more questions in that area from the audience.
Yeah.
We'll see.
So if I can summarize, you will not jail FFR wire because information that you need actually is information following main vessel stenting. What we know from multiple studies so far is that angiographically compromise of the side branch is usually consequence of carina shift, and carina shift creates actually elliptical shape of the ostium of the side branch, which is most frequently not functionally significant. So according to work of Bonk-Von Koo, actually unless we have really very tight narrowing or compromised flow in the side branch following main vessel stenting, we don't need to consider FFR evaluation. Simple balloon inflation after POT resolves at least 30% of all those compromises, shifting carina back again in the center. But in this specific case, after reviewing this, what are the main reasons why you recommend POT? You've been in the Visible Heart Lab, so you brought some of nice videos, and I think you should share those videos with us.
Yeah, the Visible Heart Lab in Minnesota actually have a model where you have an explanted pig heart beating in a kind of a Langendorf model, which means that you can actually catheterize the heart and you can perfuse the heart with a saline oxygen binding solution, which makes the heart viable for a couple of hours. And that have that extremely interesting background that if you do that, you are able to make videos in visible areas of the coronary tree. And this is such a video we will see now, which actually explain very precisely what happens. You see the angiogram on the right side, and you see actually the online video within the bifurcation in the coronary arteries. And what you see is that it's very easy to go behind the proximal part of the stent with a wire, because this stent has been implanted with respect to the distal diameter, which actually make a gap in the proximal part. And that's not very easy to appreciate that on the angiogram. It's not so clear in this video, but you can actually appreciate it on your right side. So that's the reason why we, to make a procedure safe, always do a POT before we go any further. Realize what will happen if you lose the wire in this stage and try to come back. You may go behind the stent. You may come in between some stent struts. And when you do the next ballooning, you will cross the stent partly. So this is actually a very crucial step. Do the POT after the initial implantation.
Yeah, so that's the answer to question from one of our participants. Do you consider recrossing into the side branch before POT? Definitely not, because you may go underneath the stent and you may go actually outside. And angiographically, you cannot appreciate this one. Or should we only recross after POT? Yes, that's our recommendation. Oppose stent appropriately proximal, and only after opposing the stent, we should perform proximal optimization. So this is, I think, a very relevant paper that we published there last year. Can you briefly summarize main messages from that paper, and is it applicable to this discussion?
Thank you for this. Well, what we try to do is develop a sort of an algorithm showing that everything that you do in bifurcation stenting should be according to a plan, or most of what you do should be according to a plan. So if you develop a step-by-step plan for a bifurcation PCI, you will also find, as part of this algorithm, as part of these steps, main branch stent optimization, as you can appreciate here. And as you all discussed now, as you two discussed now, the visible heart is showing you what you do not see during angiography. So in our everyday practice, we implant the stent into the main vessel, and angiographically, it can look wonderful. We cannot angiographically appreciate that there is a gap in the proximal main vessel. And as you can see here on the slide listed, there are at least 3 techniques that you can use to optimize this result. Pot, pot side pot, or kissing.
Yeah, thanks for that question. We have more questions. Do you consider recrossing before pot? Shouldn't we first visualize stent expansion with IVUS OCT before doing pot and to have idea about diameter at the ostium of the side branch? Jens, I think you already commented on that one. So we know that stent is not optimally opposed proximally.
Yeah, but I think there is an excellent question here, because we are doing more and more imaging-guided PCI. But what we have to remember is that it is actually, it's technically demanding, it takes time, but it gives us some really important information. But if you use an OCT catheter before pot, you may cross the proximal part of the stent because it's not opposed. So that's actually the first answer to that question. The next answer is, if you do the measurement, it's very important to give a lot of nitroglycerin, because what happens is actually a contraction of the vessel when you stent it. So it's very difficult with OCT to have a proper diameter measurement. So actually, to keep things safe and simple, do the pot first and then make the measurement and see if you have done it correctly.
Yeah, thanks. If I can summarize briefly what is actually pot. Proximal optimization technique, or pot, was initially described by Olivier Darmon in 2007, and very soon it became part of all consensus documents, and we really discuss this technique at every meeting, because goes in line with your initial comments that we should try to reconstruct natural 2 diameters inside metallic structure like a stent. So you can appreciate in panel 1 that if you select stent according to distal main vessel diameter, after stent deployment you have grossly underexpanded stent. To correct this, we use short, either semi-compliant or non-compliant balloon, or even compliant balloon if the lengths are available. And you position, as you can see in panel B, you position distal marker of that balloon in front of carina. So not across carina, but in front of carina, and you try to stay with your proximal end of balloon inside the main vessel stent. If you go outside, there is a risk of dissecting proximal edge. So you should select balloon length according to the stented proximal main vessel segment to be inside the stent. You position distal marker in front of carina, and you select diameter, of course, according to proximal main vessel diameter, which is usually 0.5 millimeter or at least millimeter bigger, depends on bifurcation. Then you inflate until you fully expand stent proximally, and as a consequence, you will have jailed wire, but you also have, as depicted in the panel number 4, you have much better stent expansion. At this stage, if you want, you can perform imaging and evaluate, especially with OCT, the amount of malapposition, and then select further size of balloon or higher pressure necessary to collect. And this is the effect from inside, of course, from bench testing. You see in the left-hand panel, before pot, you have multiple metallic struts in front of the ostium of the side branch. But with proper position of the balloon in front of carina, by inflating larger balloon at higher pressure, you actually open more access towards the side branch, and again, you push some metal also to scaffold better the ostium of the side branch. So you can see in panel B, after stenting and after pot, you have much easier and better access into the side branch. But of course, there are some obstacles, and maybe Jens, you can guide us through this.
Yes, I would be very happy to do that. You have already the panel to look at, but I just want to remember that the most important thing when doing the initial stent implantation is to take care of the distal part of the stent. And the reason for saying it is that the reason for pinching or closing side branches is basically every time because of an over dilatation of the distal part of the stent. And we need to know that, and we need to have it in the back of our head when we are doing the procedures, because we are so trained in putting in tubular stents, and we are so trained into having a proper apposition. So it's so easy to put too much effort in the stent implantation because we look at the proximal part of the vessel, but we should look at the distal part. Having said that, it's very well appreciated in this panel, especially in the right part, that if you do a pot too deep, or if you overdilate a distal stent, you close the side branch by pushing the carina towards the side branch, carina shift. You can of course also make plaque shift if there is a plaque that actually is pressed during the carina and during the side branch. And the last thing is you do some harm to a vessel when you put in a stent. And a thing that is really important to realize is that not very seldom there is a hematoma in the vessel wall. So when you do the pot with actually a second dilatation, you may squeeze the hematoma towards the side branch. So be aware that this is a risky part of the procedure. It's very important to have the pot balloon exactly at the right spot. Too deep causes problems. So what do you do if we actually closes the side branch?
Yes.
And that's actually what we have to discuss now. So I think we need the next picture to discuss that. Or maybe we should wait until this question.
Yeah. Let's be practical. And in your everyday practice, what kind of balloon you will select? What is the length of the balloon? Longer, shorter, compliant, non-compliant? And how you make certain that you position distal marker in the appropriate place?
This is, again, an excellent question.
But you are one of the best experts in the world, so I have to use the opportunity.
Well, actually, you have to realize that we are discussing a toolbox when you're doing PCI techniques, and you need to know your working horse balloons.
Exactly.
Actually, the marker of a balloon is not the same for every company in the market, which means that you have to make sure that you know where are the shoulders of the balloon according to the distal marker. So that's actually a thing you could do before you start the procedure. So that's the first part. The second part is you can discuss to use non-compliant or compliant balloons. It comes basically back to how extended a predilatation you have done. If you will be sure not to overdilate, a non-compliant balloon is high pressure is actually a good option. But if you do use another balloon and use a compliant balloon, you have to take care of the distal part and of the different pressure gradients you do when you use such a kind of balloon. And these are the considerations. So to be sure and to be safe, use a non-compliant balloon. So that's actually the backbone of that.
Yeah, if I may add from my personal practice, I try in the beginning to find a geographic projection which really opens the most bifurcation and visualizes carina, and I try then to work in that projection during positioning of the balloon. And if we work in delicate subset like distal left main, in that case I really want to make sure in two projections that my balloon because of foreshortening given in some projection, that my balloon may be optimal in one position, but then I go to second projection and I see that I'm actually crossing the carina. And then I have the consequence, what you said, displacement of carina following balloon inflation. And finally, it's very important to understand that during inflation of the pod balloon, if we don't cover the full length of the proximal stent, we have so-called bottleneck effect, actually partial collapse of the proximal edge. And to correct that one, we need to pull back, use I guess stent enhancement is readily available almost everywhere these days. Use stent enhancement possibilities to make sure, if you know your balloon, where is the proximal position of the balloon, and make sure that before exchanging wires, you can fully open and dilate also proximal edge. So this will be small tips and tricks.
And Goran, it's a very, very important point, because if you have the bottleneck, you will still have the risk of going behind when you come back.
Behind and in, out and in.
And I guess I totally agree with your meticulously taking care of where your balloon is before you dilate it, because it's such a crucial step in provisional stenting. And most just really realize how important this step is.
Exactly.
Another thing is, if you will play it really safe, it's better to go a bit proximal for the carina, because you can still correct it. If you go too deep, you're in problem and troubles.
We speak about jailed wire. There is a question from our participants. According to your experience and available evidence, would you prefer hydrophilic guide for the secondary vessel? Then what would you select? To jail hydrophilic wire, is it dangerous these days?
What we know from actually randomized studies is that it is safe to jail a hydrophilic wire. There is a randomized study with micro inspection of the wires that actually showed that hydrophilic wires are more resilient than the non-hydrophilic wires. So it is not a problem to jail a hydrophilic wire according to this evidence that we have.
Yeah, so you can jail also hydrophilic wire if that is one of workhorse wires that you use. Jens?
But I just have a comment here, because there is another thing with hydrophilic wires, because they're easy to work with. But when you are doing a bifurcation and maybe have a jailed wire and have two wires, and it's basic knowledge, but we tend to forget it. Hydrophilic wires tend to dissect a bit easier. And when you manipulate a lot of balloons and have two wires, keep an eye of the distal tip, because they will perforate now and then.
Yeah. So you need to position image to see tips of both wires.
Yeah.
Yes, we need to go to very readily asked question, but something that I think is the most frequently asked question at any bifurcation seminar. Should we remove jailed wire before pot? Yes or no?
No.
No. So that was simple. Now can you help us understand why so simple answer no? What is the advantage and disadvantage?
Well, actually the jailed wire is the protection, and what we have discussed is have a safe procedure. So if you are in doubt, put in two wires. I'm very close to say put always in two wires, but I don't think there are situations where we don't put in two wires. But if you're in doubt, put in two wires. If you close the side branch, you have a marker, so you can see where it was when it were there. You also have a wire in the right lumen, because what happens when you close the side branch is that the ostium is narrow. And when you come in with the next wire, it's very, very easy to force it into the wall and make a dissection. So the jailed wire it's actually in the right lumen. If you have a situation where you close the side branch and have the wire jailed, there is a rescue technique which is actually depicted in the panel in front of you. You can see from the left side that the small balloon in number 3 panel is actually a small balloon which is possible to put over the jailed wire and behind the stent slots, although they are properly implanted. Slightly move the balloon. You could use a microcatheter as well, but you have access over the jailed wire behind the stent. You can dilate a bit and make flow in the side branch. You can even stent the side branch behind the already implanted stent and then correct afterwards. So this is a rescue procedure.
Yeah.
You may not need two wires always, but you don't know before if you do or not. And if you put in one wire and need two wire, you will always put two wires in the next time.
There is a question, do you prefer high pressure for pot?
Yes, basically yes. But,
yes,
but
no.
Well, yeah, it depends on the procedure. If it's a side branch that I'm very keen of protecting, I use high pressure. even I have jailed a wire, because I would like to be sure that I have a proper position, open stent slots towards the side branch, and avoided the bottleneck. So that's actually...
Yeah, I think we really have some experts also following this webinar. It's worth mentioning to make sure that side branch jailed wire is not knuckled. You agree, of course.
Yes, I agree.
Thank you very much for that comment. And another expert comment is there a difference in pot positioning for decay crush and for TAP, for TAP, because of the position of new carina? You want to comment on that, or?
Yeah, actually, I would like to comment also on the knuckle part, because just before we mentioned that hydrophilic wires tend to dissect. So we don't want to knuckle them, but actually we want them to bend up, which actually do to take care of and avoid perforation. We may end up with a knuckled wire. And just if it happens, it may be safe to put in a microcatheter behind the stent to unknuckle the wire. Otherwise, you can cause problems. According the DK cross is actually for another webinar, but just to answer shortly, yes, there are important corrections of the DK cross technique done by POT on different steps in the procedure. And I think we should...
but balloon positioning is the same, because it has nothing to do with DK crush versus T or TAP at the first stage, because you position distal marker in front of the carina in order to open access. So the fact that DK crush has metal between vessel wall and proximal part does not influence the position of the first pot. When we speak about second pot after TAP, in TAP we have new metallic neocarina inside the main vessel stent. So it's big discussion whether to perform at all second pot in TAP because of the metallic neocarina. If you start inflating, first you have expansion of the balloon radially. But then after achieving certain pressures and some pressure goes in longitudinal direction, you have elongation of the balloon. So by elongation, you can distort and push carina. So I'm not so sure if we should deliver message that TAP and final pot are really certainly recommended. First pot after main vessel stenting, definitely yes. There is a question, is there...
but Goran, I need just to make a short break here, because the question was in DK crush. And actually...
Between DK crush and TAP, is there difference in position of the balloon? Just balloon position, pot position.
I know, but actually, and this is a long discussion, and of course it's not in a provisional stent webinar, but now we have raised the question. The thing is that one of the risky things in DK cross is actually that you don't cross enough. And that means that you have to make a much more intense and precise pot in DK cross to make sure that you make the initial start of the procedure right.
Yes.
And then I totally agree with the rest you said, yes.
Because he's asking just about position of the balloon, not about technique. Technique of crushing does not really goes for...
Yeah.
I think we should move on with the discussion of pot, because definitely pot is mandatory step in every provisional. You use pot because you need to optimally expand proximal part of the stent, and you use pot in order to re-establish and reconstruct natural anatomy of bifurcations, as you said. And here is the result after pot. So operator in this case has performed pot. This is a still frame image. You can clearly see two different diameters, one bigger proximally, one smaller diameter of the stent distally. So is procedure done at this stage? Would you perform kissing balloon at this time?
Again, it's an excellent question, and it shows the beauty in the provisional philosophy that you go stepwise and you re-evaluate. We had a question in the beginning where one in the audience stated that he would definitely stent the side branch because it's diseased. and it was just before we started the procedure. I agree there is disease in the side branch, but should we be strict to the philosophy? We should go for balloon angioplasty, which make sense, because if we succeeded with balloon angioplasty of the side branch, we don't need a stent, but we corrected the disease. So yes, in that case, if we go with the balloon in the side branch, we should, of course, do it in the main branch, and then we should do kissing.
If we do kissing, then what is the summary of recommendations? Why we do kissing after POT?
According to the sheer mechanics of kissing balloon inflation, what we could achieve is improve the expansion in the proximal main vessel, improve the result at the ostium of the side branch, and also regain the central position of the carina. Those are three things that we mechanistically will achieve with kissing balloon inflation. However, we need to be aware of the fact that there are also side things that we do not want to achieve, but that happen with kissing balloon inflation, like, for example, elliptic deformation in the proximal main vessel or arterial overstretch in the proximal main vessel. Those are the things that we do not really want to achieve, but that can happen with kissing balloon inflation.
Yeah, to avoid or to limit these detrimental effects of kissing, we try to standardize the way we perform kissing nowadays. So this is the picture how we believe it should be done. So we should select short, non-compliant balloons if we want to do kissing. Especially it's relevant for the side branch, because we really don't want, by increasing pressure, to dissect the ostium of the side branch. Sizing, another very frequent question. Sizing of the balloons should be according to distal reference of the main vessel and distal reference of the side branch. Since we already have stents selected according to distal reference of the main vessel, usually it's NC balloon, the same size as the stent, and for the side branch we should select NC balloon according to reference diameter. Position is also very important, and that's why we select short balloons. We should try to short overlap proximally. We should try to stay in the bifurcation polygon of confluence. Actually, in that segment, we have the largest diameter, and the damage created by overlapping balloons is the smallest. So short proximal overlap. And what is very important, we should try to keep balloons inflated for at least 20 to 30 seconds. If that is not possible because of symptoms of ischemia, we should, of course, perform 2 or 3 shorter kissing inflations. And finally, what we learn also from bench testing, and we should try to apply in clinical practice, is that we should do sequential kissing. So we don't any longer simultaneously inflate both balloons. We start by inflating side branch first. Therefore, we are removing metal from the ostium of the side branch. We go to 10-12 atmospheres. Then we slowly start decreasing pressure in the side branch balloon. We start by inflating main vessel balloon. And then we achieve 12, 14, depends, you see on the angio, full expansion of the balloon. And at that moment, it's very important to do sequential deflation, simultaneous deflation of both balloons. Jens, did I miss something? Would you like to add?
No, I think you make that stepwise very, very clear. But what is again important is that when you do provisional stenting, you have to train your technique, because a kiss is not just a kiss. A kiss is a perfectly proper done kiss, which have 2 main options: to correct the carina and to open the ostium of the side branch. So I totally agree with your description.
Yeah, thank you. So actually, frequently people ask why we do kissing in left main, because that's the only way to put carina in the center. And you said in the beginning you want to reconstruct natural anatomy. Natural anatomy means a central position of carina. From the very beginning, we have multiple questions on POT, side POT. I think it's very relevant technique. At the moment, we still don't have enough evidence, clinical evidence, to recommend this technique as a routine. But what is the sequence in POT, side POT? It's actually after first proximal optimization, we exchange the wires, and then we go with adequately sized balloon into the ostium of the side branch, open struts, As a consequence, we always have main vessel stent deformation following that inflation, and we correct that stent deformation by second pot. So pot, wire exchange, second pot, predilatation of the ostium, and then second pot. We have one registry from France. It's published in Neurointervention. In that registry, we have good result, good data, but we need to collect much more, because I don't think that based on one single registry, we should recommend as routine alternative to kissing, because this is the relevant question. Should we use kissing, or we should probably replace kissing by pot side pot? I think that we still don't have enough evidence to recommend. In some side branches, which are relatively smaller, I personally accept pot side pot as option. But in my everyday practice, if you have large side branch, what Dejan discussed, if you have Finet law or Murray law, that you have 3 diameters which are interdependent. If you have large side branch, it means that discrepancy in diameter in proximal and distal main vessel is very large. In that case, I believe pot side pot is not appropriate to fully correct and expand. I believe in large side branches with large discrepancy in diameters, kissing plays a role in better expansion, plus pot side pot will not put carina in the center. So I think this is another thing that needs to be corrected by kissing. What is your...
May I add a bit to this discussion? Because if we take the simplistic view and try to keep things simple, it's more easy to do kissing and pot. Because what happens is actually, if you do the kissing, you open the area just around the takeoff of the main vessel and the side branch a bit more, which means that you can make a more proximal pot, which is more safe.
Yes.
So that is a much more safe procedure, because if you do a proper pot side pot and then do a too deep pot,
yeah, maybe
then you ruin the entire result.
We should show the visible heart images, I think.
Yeah.
This is the whole sequence. Maybe you go, Jens, through the sequence.
So actually now we are back in the visible heart study, and actually from Minnesota and supported by Medtronic. What we see here is actually a direct video inside the vessel of the stent implantation, taking part of the distal part of the vessel. As you can see in the right panel, this is a loop, so now we are starting again. The stent goes in. As you can see, there's actually a wire wrap, which is not very much appreciated in the angio panel. Another thing that you can see is we are very precise in taking care of the distal diameter. And what happens in the proximal part is there's a floating stent, which is very easy to appreciate here. So now, now we have the first step in the journey, as we discussed. And that actually underlines the importance of why we exactly after this would like to do a pod. So this was actually done. And what we are doing after the pod, you can realize that the stent is much better opposed. What you see now is actually that we are preparing for the kissing. Again, there's a bit wire wrap. We couldn't see it in the angio, but it's very, very easy appreciated in this panel. We can discuss the position of the balloons and the sequence. But
short overlap, yes.
Yeah, which is actually taking care of the bifurcation area.
And there is a question, the position of the side branch balloon for kissing only nose out, so short. You don't need to extend the length of side branch balloon. You just need to go, as correctly suggested, nose out, just to remove the struts.
From this question, yes, that's true. But we again need to discuss that one of the things we really would like to gain with the kissing is actually the carina position. So you have to go a bit into the side branch to make sure that you have force enough to push the carina. So it's a trade-off, and you need a proper position. Okay, so after that we actually need to do a repod, And it was what we were discussing before. You can actually see through the balloon that it seems that we are too deep, because it's difficult to place the balloon. And if you do a pot too deep, there you see what happens.
You push metal into the main vessel.
You put metal into the main vessel. Actually, you could see, if you really will go into details, that we may not have been in the most distal strut, because there was actually a metal carina. What we have to do now, after the report, when we realized that it was not very good, we have to actually run through the sequence again, do a new kiss and a new pot. We did that, and this is actually the final result, and you can realize that down the carina is in the middle. There's a bit of metal carina, but the position is good, and we have a very, very easy and smooth access to the side branch.
Yeah. There is a question, when performing kissing, do you recommend to perform balloon dilatation of side branch first with undersized balloon, and then you perform kissing with properly sized balloon? Do you open struts, or you go directly with...
That's exactly what I was going to say. If there are no problems, if you can advance the properly sized balloon, just do it, because you're not going to lose time.
I think there are a few more interesting questions that we can address at this point. In arterial STEMI context, you find bifurcation Medina 111 at bifurcation site. Do you think that even in this context you should use provisional?
Personally, I always use provisional in this situation, because I would rather stop in the procedure when I have saved the main vessel, and maybe come back a day or two later after antithrombotic treatment to see if I had to correct with a stent more. So that's actually what we are doing.
Maybe two short things. First, Medina 111 doesn't mean that there is a long lesion in the side
STEMI,
branch.
yes.
Yeah, exactly. And also in STEMI, thrombus may obscure the vision and the appreciation of the lesion. So after the thrombus resolves, we have a better picture of the lesion.
One question is, if I understand properly, when we use kissing and when we use decay crush, so these are two different topics. We use kissing in provisional and in decay crush in order to better expand stent proximally and focus and positions carina in the center. So we use decay crush with kissing inside the decay crush. In provisional and in decay crush, so that's probably the question for our colleague. We use kissing in case that we need to expand better stent proximally, and because we want to position carina in the center.
Goran, we are discussing the toolbox actually.
Yeah.
And kissing in DK cross is actually two things, because DK is double kissing.
Yes.
And the first thing is not for stent apposition and correction, it's for making the procedure smooth and easy.
Exactly.
Yes.
And this is the result, or final result of your procedure.
Yeah.
After kissing and more proximal repot. So if I can summarize again briefly, kissing, if it's adequately performed, has immediate benefit from the perspective of better stent expansion proximally and positioning of carina in the center. Final pot after kissing, even if it's done, should be done probably more proximal, because if we go too distal, like with the first pot, we are in danger of pushing carina in one of the two directions. So I believe that this is the result after stenting and after kissing balloon inflation. So in this case, would you, Jens, again, question for you, would you continue immediately and put side branch stent now?
Well, personally, I would not do it, but I appreciate that there's still disease in the side branch, although we have already kissed. So I think I would give it yet another go, because I think it's more important to keep the metal load low and to keep the procedure simple. If I put in two stents in this situation, no matter how good I am in placing the stent, I will theoretically jeopardize the main vessel, which is the most important. So I'll go very long before I put in the next stent. So I would actually try to do a longer balloon inflation with kissing and see if I could correct the diseased area just by plain old balloon angioplasty.
Okay, I'm in advantage compared to you because I know that operator performed exactly as you suggested, long inflation of the balloon, and by repeated long inflations, he dissected diagonal, so he was forced to put second stent. So if I try to round up what we discussed today during this session, optimization is actually key step of bifurcation stenting. And it's actually key step in our provisional philosophy. We are not afraid of putting second stent. It's just a different approach. One school that, Jens, I really respect, and your clarifications were useful for all of us today. You start by stenting main vessel first, and then you evaluate at several different stop points what would be your next step. But each of those stop points is actually stop point between two steps of optimization of the initial result. So you optimize by performing proximal optimization, you evaluate result. If you are not satisfied, or if you think that side branch is big and you need better optimization proximally plus central position of carina, you proceed to next step, which is kissing. After kissing, you evaluate. If you have short proximal overlap and maybe some probably unacceptably good apposition in the proximal edge, you will go with second pot, more proximally, to make sure that proximal edge of the stent is fully expanded. And at that stage, you make decision whether you are going for second stent or not. There are many different options. These options mean you should perform each of these steps correctly. We try to specify as much as possible in this short time period to use either non-compliant or compliant balloon for pot. Try to avoid crossing with distal marker carina. Try to avoid expanding balloon outside the proximal edge of the stent. And by increasing pressure and using probably compliant balloon, you can improve also result of the proximal optimization. On the other side, for kissing, we use short non-compliant balloon sized according to distal. We inflate sequentially, starting with side branch inflation, then main branch, and then simultaneous deflation. If necessary, we can perform 2 or 3 times short 10-second inflations, and the result is the same as single kissing of 30 seconds. And final pot is probably mandated again in order to optimize the most proximal aspect of the stent. So final pot probably for big bifurcations, and if we are not sure that we have fully expanded stent. We see a lot of space for including imaging as a guidance during the procedure, not that much functional guidance, but imaging, OCT or IVUS, depends on what is available. By performing these techniques, we are able to optimize immediate result, but we are ready to put second stent if necessary. After stenting of the main vessel, we have different options. We believe that each operator should select two-stent technique, which is for his philosophy the easiest, the most comprehensive. He should practice a lot, 1 or 2 techniques, for example, TAP for wide bifurcation angle, or T, if possible, and better T without protrusion, and either DK crush or culotte for narrow angle bifurcation. And we should not be afraid of stenting the side branch if result is not adequate. In this case, result was suboptimal, so considering side branch if necessary was done because, as you said, after dilatation we compromised the flow, and TAP stenting technique was used for diagonal branch. So I believe that for the purpose of the seminar, we intentionally focus today on stent optimization as probably the most important aspect of provisional side branch stenting strategy, and we will see in the next session how to optimally perform TAP technique. and there is a session in the context of bifurcation continuum during EuroPCR 2019, learning how to optimize techniques in Provisional, Tuesday 21st of May, 12 o'clock in Theater Havan. So this is the final result. And any final comments, Dejan, Jens?
Well, we need optimization to adjust our result, to adapt our result to the underlying anatomy. So in the first step, we understand the anatomy. In the second step, we use wisely and correctly optimization techniques to reconstruct the original anatomy.
Yes.
We need a toolbox.
And use it properly.
And learn how to use it when needed.
So we have now reached the end of this first PCR webinar in our bifurcation continuum. We hope you have found it useful. On behalf of my colleagues, Jens and Dejan, I would like to thank Medtronic for supporting this independent series of educational programs on bifurcation PCI. The next PCR webinar on bifurcations, entitled Imaging and Functional Guidelines for Left Main and Bifurcation PCI, is on Wednesday, 24th of April, with participation of our esteemed colleagues Javier Escanet, Emanuele Barbato, and Nicolas Amabilo. All the best from three of us.
Thank you.